It started with her questioning it all. Do you think hyperbaric oxygen should work for this? You know, it's a lung problem. You're breathing in 100% oxygen. There should be a direct effect on the lungs, and that's what people are dying of with COVID. What do you think? History bears remembering. In medicine, everybody forgets anything that's 25 years or more old.
This is Doctor Talks.
Well, welcome. This is another Overcoming Long COVID and CFS, or chronic fatigue. And today we have a really special guest. I'm very excited because I love bringing new information, but I'm especially excited when I'm going to learn a lot. And today I have Juliette and Paul Harch with us. And Dr. Harch is a professor of emergency medicine and hyperbaric medicine at the LSU, Louisiana State University School of Medicine in New Orleans. And he is the man who has really put hyperbaric oxygen, I think, on the map. I mean, he's taken it to new dimensions. And so we're just going to start off. One of the things that we were just talking about before I hit the record button is how he got involved in hyperbaric medicine, because it really wasn't a thing, I don't think, too much. So we're going to start right there, and then we're going to roll into like what its use is and why we think of it with long COVID and also just with COVID, it sounds like. So Dr. Harch, tell us your story.
Well, I'd always wanted to be a surgeon. I was in a surgical residency and was involved in a very bad motor vehicle accident and ended up having to take a medical leave, finished 2 years and needed another operation and took another medical leave. And once out, I wasn't so sure that I could or wanted to continue. And I ended up finding a job just to support myself in emergency medicine, and evolved to accepting what I thought was a temporary job in New Orleans. And when I went down there, I joined an emergency medicine group that was also the diving medicine, hyperbaric medicine, wound care center for the city and for all diving accidents, South Central United States and Gulf of Mexico. And we had the option of getting involved in diving medicine. Of course, it's not taught in any medical schools, but I was interested in it. And I thought, okay, yeah, let's go learn about this. And as soon as I started seeing the patients, I was intrigued by these divers who would come in, and, you know, everybody's familiar with the bends involving joints and, you know, the kind of orthopedic presentation and spinal cord injury. But so many of these divers were just not right in their head. They were spacey and slow and, you know, a little confused and just off. And I started asking questions about it. You know, what's going on in their head? Are we bubbles there? They go, nobody knows. I go, really? Well, what are we treating? No one knows. Well, what do? Put them in the chamber. Well, we put them in the chamber and they come out and they're better, but they had residual neurological problems. I said, well, wait a minute. Did we treat the bubbles? No one knows. Well, how many treatments does it take to get rid of the bubbles? No one knows. And I thought, my God, this is the most primitive area of medicine. It's been 80 years in the making, and they can't answer some very simple questions. And in the midst of it, I started delving into and looking at brain decompression illness. And in particular, the US Navy had published that single treatment, first treatment was curative in 90% of cases. We had about 40%, and nobody could answer why. Turns out it was the delay to treatment. And we weren't treating what the Navy was. So New Orleans is 90 miles upstream from the Gulf of Mexico. And by the time the divers would get in from the Gulf, by land then, and maybe try to sleep it off and drift in a day, 2 days later, whatever, we weren't treating the same thing the Navy was. And then in the midst of it, I made a discovery that Navy was telling us if it's 24 hours or more, forget it. They got what they got, they're stuck. And I kind of took a flyer, if you will, with some of these divers who were significantly delayed and significantly damaged. And I treated them at a different dose, and lo and behold, these guys improved. And we captured it on brain imaging when Nobody was able to see this on CT or MRI. We could see it on brain blood flow imaging. And once we were able to prove this unequivocally, and it was a clinical finding, I went running to scientific meetings to show this stuff. Nobody wanted to believe it. And it was resisted with vigor because I was showing this in the signature diagnosis that contradicted, if you will, what the Navy had taught. And so the question then arose, well, wait a minute, we're treating subacute, maybe chronic brain injury here. What else? Well, we simultaneously were treating a New Orleans boxer 23 years after his last bout, dementia pugilistica, and then the first cerebral palsy child, old stroke, toxic brain injury, residual, and this whole thing mushroom. And essentially what we were able to demonstrate is that hyperbaric oxygen is a generic drug for chronic brain injury and even subacute brain injury, almost irrespective of cause. And that's where we ended up. And then the latest edition was due to Juliette and what she started talking about with COVID. So that's my story, if you will. It was taking a clinical observation, asking questions that nobody could answer, that was so basically simple, and then treating some patients that were untreatable. And the result was so powerful, I couldn't walk away from it.
And so what year was this about?
1989.
Right. Okay. Well, because what I like people to understand is how difficult and how slow change medicine are. Because I don't think people appreciate it. They and the work and the dedication to keep going, because this is, 33 years now. Okay. And still, hyperbaric therapy is one of the best kept secrets in America.
Unquestionably. And another little caveat here is that I showed this in divers, but it was not new. The lower pressure treatment, hyperbaric oxygen for a chronic neurological condition. My mentor, one of my mentors, Dr. Richard Neubauer, had been doing this for 12 years and just getting all kinds of resistance. The Russians had done some of this back in the 70s and 80s, other people along the way. But one of the problems was none of these people had academic positions. They were in freestanding centers or other places doing hyperbaric, and nobody wanted to believe it. And they were easily discarded by the academic community. And I thought, oh, we gotta have an academic position. And my senior partner ended up, and I helped, we started a fellowship at LSU, and we tried to do the academic track to this. But even with that, it just tried to turn around a 100-year-old boat that the medical profession had discarded. It was, and still is, difficult progress, but we're making progress.
Okay. Well, I want to get to Juliette and and COVID, but I just want to emphasize again is that if there was a way to make $1 billion on this, this wouldn't be a problem. Okay. That's what I think. I'm not sure if it's every recording I say this, but it's frequent. In this day and age, we have, evidence-based medicine. And I always like to remind people that it is really evidence-bought medicine. If you have, $100 million, you can start the study. If you don't have 500 million, you're not going to get it to the FDA, or maybe even $1 billion. I mean, it's that much money to get something new really approved from the ground up. So just people have to understand that this is not from any bad intent. It's just what happened. We kept trying to protect ourselves to the point now where we have big fences to prevent us from helping ourselves, because the work that you're doing, the work that you did in '89, you might not even be able to do today. If you were in a medical center, they wouldn't let you.
Well, none of this has been done at the university. All of this has been done in our clinic and put under, at times, the umbrella of an institutional review board, to do the experiment. But all of this has been done in our little clinic.
Yeah, he works 3 jobs.
So,
Yes, but okay. So enough about the. It's not really the politics. It's just the unfortunate realities of medicine today. And I said maybe one of the unsung blessings of what COVID is bringing is we're going to have enough people look at things differently. Maybe, there's a lot of money being thrown around and some really smart people, but maybe nice to get some of it thrown your way, and we can publish a little more. But so Julia, how did you get in the middle of COVID and hyperbaric?
Well, in February of 2020, I kept on nagging him to write something about HBOT for COVID, because once, with hyperbaric oxygen, once the red blood cells are completely saturated to 100%, the oxygen under pressure dissolves in the plasma. So I thought that's a way to get oxygen to the lungs, because these people were suffocating on the respirators. And it also reduces inflammation. So that's what I saw as the problem. And also it worked for the Spanish flu. So I kept on telling him, would you please write something so we can post it on the internet? It's like, yeah, later. You've got to write something about this. And then he finally did, and boom. Go ahead.
it started with her questioning it all.
Yeah.
Don't you think hyperbaric oxygen should work for this? It's a lung problem. You're breathing in 100% oxygen. There should be a direct effect on the lungs, and that's what people are dying of with COVID. What do you think? And I said, well, everybody, history bears remembering. In medicine, everybody forgets anything that's 25 years or more old. But what was the advent of hyperbaric oxygen or hyperbaric therapy into the United States?
The Spanish flu
pandemic. And then we went over and discussed the whole story of this. 1918, Dr. Cunningham in Kansas City, anesthesiology professor, was in Colorado in the Rockies vacationing. And he got to thinking, about why the mortality for Spanish flu patients was so much higher in the Rockies. And he said, it's got to be due to the high altitude, low pressure, and low oxygen level. What would happen if we gave these Spanish flu patients more pressure and more oxygen? An epiphany, raced back to Kansas City, and he bought an old boiler and cobbled together a hyperbaric chamber. The day it was operational, he had all these planned animal experiments, and he was brought a dying Spanish flu patient.
He was a medical student.
And
The
I think it
patient was a medical
student. Yeah, and it's described in a book and in a separate journal article in Laryngoscope by one of his residents, how they brought this patient in, agonal breathing, blue-gray, taking his last breaths. They put him in the chamber, and they didn't have bulk oxygen at that time. It was just compressed air. And they described this guy pinking up, his labored breathing, starting to breathe better. They did one treatment a day for 4 days, and the guy was salvaged. And next thing you know, there was a steady stream of dying Spanish flu patients brought to him. They were overwhelmed with it. They ended up building a 108-foot chamber, then a 5-story steel ball hospital chamber. And that's how hyperbaric medicine started in the United States. So I was talking to Juliette. I said, man, this has been done before.
That story.
And she knew the story and reminded her of it. And she said, why won't you announce this? So we put an announcement on the web about this. Look, there's no treatment for this, but this has been done before. Spanish flu, coronavirus, they're nearly identical. They cause death by respiratory illness, ARDS, and so on. And the day after I posted that on March 10th, she found an article out of Wuhan, China, where some hyperbaric doctors had treated a handful of patients. And one thing led to the next. We had an interview with these doctors, the treating doctors in Wuhan, through a translator.
And he helped the doctors in Wuhan translate their research into English.
And we couldn't get it. Yeah.
Get it published.
Well, what ended up happening, they finally decided to publish it in a Chinese-speaking journal. And so it's in 2 journals. But I took what they had done, part of it that had been released on the internet, and had a commentary that got published in an English-speaking journal, Medical Gas Research, and it said, look at this. There's precedent for it, and now here The Chinese have done this in Wuhan and salvaged 6 patients, 1 on a ventilator. And next
So-
thing you know, multiple studies have been done, and
So you could
eventually
imagine,
long haulers.
you could imagine how excited we were to
Yeah.
absolutely know that hyperbarics was healing people in Wuhan. And we just thought that would be like on the front page of the New York Times, on the 6 o'clock news. It went,
Nowhere.
Well, it at least, well, yeah, I mean,
Well-
we put this in front of
I'm
Governor
surprised they
Cuomo,
didn't-
but we got it in front of Como. We did get it in front through a courier.
and Louisiana Governor John Bell Edwards. I gotta
Oh, yeah. he was
explain
wonderful.
this.
He was wonderful.
He was so supportive. He gave us $1 million to do the study,
Right.
and we would not get the hospital to approve the study. LSU's IRB
So
did,
we never,
but the hospital would not.
so we could
And-
never do it.
And
And we
we
had the money.
were right here at the epicenter, one of the epicenters of the country, New Orleans, high mortality, sick people. But
Oh my God. Oh my
Couldn't get it-
God.
But you know what?
Just-
But you know what he did? He wrote the IRB, and we published the IRB and sent it to everyone
put
we
that
could
out there.
possibly, and put it on the internet so that other doctors could use it at other hospitals all over the world. And we got emails from doctors from all over the world.
Were you?
But it still did, it still wasn't
Yeah.
publicized. It didn't
Yeah,
go
but
anywhere.
it's still, I mean, just one question is that I thought in the beginning in New York that when they were intubated, so discriminate for me and for our audience, the difference between being intubated, because I think the pressure obviously has a lot to do with this, the pressure on the body, not just shoving oxygen into the lungs, because that didn't seem to work so
Yeah,
well.
yes, it was, the intubation was damaging the lungs. In
Yeah, I
addition
mean,
to
so-
COVID.
two points there. Yeah, I'm sorry. Go ahead. Did you finish?
No. I just, you got the idea. Just tell us the story about what really is happening physiologically, why it's so different.
Because it is the effect of barometric pressure, appears to be primarily. And this is what, when I pointed this out to the treating doctor in Wuhan, I said to her, are you familiar with what happened with Spanish flu in the United States? Hyperbaric medicine, Dr. Orville Cunningham? No, they had no idea. I said, inadvertently, you have duplicated what he did, but he did not have oxygen. He just used compressed air, and it was likely a little bit of oxygen effect there, but the pressure itself, barometric pressure, is bioactive. And she just was this animated explosion of conversation between her and the translator. And it went on for almost 2 minutes. And I finally said to the translator, what is she so excited about? And he said, she was trying to tell her fellow doctors in Wuhan that she didn't think it was the oxygen, that it was the pressure. Because what happened was, when they would bring the patients down for the hyperbaric treatment, they'd have to take them off their oxygen, put them in the chamber on oxygen, and then they shut them in. Adjoining and connected to it was another chamber with the medical staff in, but they never went in the chamber with the patients. And what would happen is, once they shut that door, some of the patients, their mask would come off, or they wouldn't get it on adequately, and nobody went in there to help them out. But what they noticed was that even when the mask came off and they just were breathing chamber air, not oxygen, their pulse oximetry didn't drop. They didn't deteriorate. They were okay on chamber air.
Yeah.
And there is so much literature on the effects of barometric pressure, but been ignored by the entire hyperbaric medicine field, essentially for 360 years. And that's what we were trying to point out, is that it is not only some degree of oxygen, but it is the barometric pressure that is so bioactive and anti-inflammatory.
Yeah.
Yeah, that's so interesting. I mean, I always like to tell people, that's when they're, when the people who can predict the weather, when the barometric pressure is dropping.
Exactly. Exactly. And look at high pressure days.
Yeah.
Sunny high pressure days that people feel good.
Yeah. Yeah. It's amazing. We are connected to this world.
We are. We are under pressure all the time. And atmospheric pressure varies on a day-to-day basis as much as 10%. In fact, they've shown that when pressure drops from front coming through, ICU mortalities go up.
Wow. Yeah, because the inflammation goes up. Yep.
And reduction in oxygen level.
Oh, okay. Yeah, that's true. That's enough to throw somebody over. This is so exciting. Okay. So you got this, and then you basically weren't able to treat acute COVID patients.
No, we were not. Even with the governor giving us this $1 million gift, we had everybody lined up. We had the diving company was going to bring in this big multi-place chamber, have it all outfitted, put right on the ER dock next to the hospital. And just as an aside, this could also be done with every commercial airline. You can pull any jet up to the hospital. They are pressure vessels.
Right. Yes.
You can see hundreds of people at the same time and
they're plumbed with oxygen.
We could have saved so many lives.
So that is, I mean, we had a small story. As I've told many times on this, that we were spared, the ravages of COVID in Marin County where we were, because by and large, I mean, there was COVID, but it was minimal, especially the first year, because everybody locked down, nobody left, everybody worked. I mean, except the nice people who had to work in the stores, but everybody else just hid in their homes. And we had proposed an IV vitamin C therapy, the same idea, because the data on this, and we were gonna, and nobody wanted to help. I mean, the hospitals, nobody was interested. We talked to them, and it was all the same thing. There were so many ideas that just got shut down. I mean, it's incredible, but yours is especially because you had, we all had data from China, from history, that this stuff works.
Exactly.
And it just blows my mind that we couldn't, that even in New York, where people were dying like flies.
Well, they did treat a few people at NYU Langone. They did treat a few.
Yes, that's where one of the studies was done, was NYU. It was the Long Island campus that did the study, Dr. Gorenstein, and that's published. And they used a matched control group to show that they had a reduction in mortality and an improvement in overall outcome for patients. Mm-hmm. So, and now there are, I just, as I was telling you earlier, today for our LSU Hyperbaric Medicine Fellowship, every Wednesday is our didactic rounds. And I gave them this exact lecture on hyperbaric oxygen and COVID disease. There are, I think, 11 studies now that have been published on it. And the bulk of them, they're almost all positive. And the most recent one was just earlier this year. It was a randomized trial in South America, I believe it was. And they stopped the trial prematurely at an interim analysis because there was such a discrepancy between the hyperbaric oxygen and control group. The hyperbaric oxygen group had normalization of their oxygen levels in 3 days versus 9 days, the patients in the control group. And they stopped it.
Yeah, because
it obviously works. Statistically,
it obviously works. Yeah, now we just got to get people to do it. So that's acute COVID, and obviously we don't have many buyers on that front in America. And now, long COVID, because as we've been talking to people. Yes, this is we do believe this is a local or an inflammatory disease.
Yes, exactly.
So just tell us about hyperbaric and inflammatory disease, and also while you're at it, I'd love the details on how, like, so how much oxygen versus how much pressure. I mean, you can throw that in the story anywhere you want.
Great question. So just a little backtrack here. Please. What's hyperbaric oxygen? How does it work? Nobody has really understood this for 360 years. However, we have here epigenetic therapy. So, it's been used primarily for wounding conditions, one type or another. And to treat a wound and heal it, you got to stimulate growth of tissue. Stimulate growth of tissue, got to go through the nucleus. Somehow you have to signal the cells to multiply and divide. And what has been shown is that a single hyperbaric treatment, human cells, you turn on and turn off over 40% of the protein coding genes in our DNA, which is 8,101 of our 19,000 genes, from a single treatment in the 24 hours ensuing. When they've looked at the actual genes turned on, the largest clusters are the anti-inflammatory genes and the growth and repair hormone genes. Largest clusters of the suppressed genes are the pro-inflammatory genes and the genes that code for cell death. So every treatment, we're inhibiting inflammation, stimulating tissue growth, and turning off cell death. Well, as it turns out, the pressure component of it, so oxygen and pressure component is more the effect on anti-inflammation, suppressing the pro-inflammatory genes. And the oxygen effect has more of an effect on stimulating the anti-inflammatory genes. So that question of what pressure, how much oxygen, it's not exactly known. But what people have done is there have now been, actually the news, CBS News in New Orleans, one of the reporters came to me and asked me if I had treated any long haul COVIDs. I said, no, I'm dying to, because I know they'll respond, because it's an inflammatory thing. Hyperbaric oxygen, multiple review articles, has anti-inflammatory effects. And anyway, she referred some people, and I went about treating them. But the point was, subsequently in the literature, some case reports started appearing, and then a series of 10 patients, and then finally a randomized trial. These were all done at high oxygen pressures, but using QEEG and just clinical dosing also. I have had people now, I've had over 25 long haul patients, and I've found they can respond along a whole pressure range and oxygen, but it's individual to them. So it's finding what dose is best for them.
Because
And that's
not
what I'm in the
all,
process of doing.
not all long haulers have the same symptoms. They're all full of inflammation, but some of them have new onset arthritis, some of them have skin conditions, a lot of them have brain fog, a lot of them complain of fatigue.
Well, it's like
there's a variety. And then also people come in with a variety of health conditions before they got COVID. The athletic type compared to maybe the chubby, not so athletic type.
Essentially,
there's all different types.
it's practice of medicine. We're all individuals. It's like you, any doctor. You're trying to treat each patient individually, as opposed to one size fits all in some canned protocol. It just doesn't work.
We are now living in the world, in the age of canned protocols, and again,
Yes.
We don't live in that world, not us.
Yeah, no,
Not
we're
you,
trying.
not you.
Yeah, because canned protocols work, they're Band-Aids, at best. They very rarely will ever get to the basis of healing for the individual, but they'll stop the bleeding. I mean, and that's modern medicine. Like I said, just even like when you think of hyperbaric, I mean, it really, warfare is, is where we develop these tools, and then we have to figure out how to use them intelligently rather than in mass production. But again, we've lost that skill set. And so I'm hoping that as long as people like you are out there coming up with ideas and persevering and publishing, I mean, that's the point that I really want to make is how important it is that you actually keep, writing and getting information out there.
I am actually, in the past, about 3-4 years ago, I decided that, I'm in a unique position by history, by what happened, by just so many different events that have coalesced, and that my greatest contribution, I think, at this point, is to try to get as much of this in writing and to amplify and disseminate this the best way we can. So that's kind of, I'm still seeing a lot of patients and all, but my responsibilities down at the university are more for 1 day a week teaching. And then I'm spending time putting all this stuff together. So you'll see more and more coming out.
Oh, good. And it's just getting it out, because I'm constantly amazed how many amazing therapies are out there, and
Yes.
they, like you said, nothing works all the time, but we have so many things that work a lot of the time, and we don't know about them. I mean, and hyperbaric is such a perfect example. But so tell us more about, so what got you to start using the QEEG, because that's quite a different idea. I don't think many people would think about QEEG and hyperbaric in the same at the same
No,
time.
not at
So
all.
what's the evolution, and how has that changed your ability to treat people?
It's a great question. When we made the initial discovery on treating chronic brain injury, one of my mentors, Dr. Richard Neubauer, who had been doing this 12 years, he was never able to capture the improvements that patients would experience on CT or MRI. We've since been able to do that, but it's a special circumstance to grow enough new tissue with hyperbaric oxygen to see it grossly on a CT or MRI. However, you are changing function through all of this gene expression, through all of the other things that are happening. And so you can capture it on functional imaging. And in 1990, he published a single case. It's called the idling neuron, letter to the editor of Lancet. And it was a 60-year-old lady, 14 years post-stroke, severe deficits. And they did a brain blood flow scan and then put her in the chamber the next day and took her out and repeated the scan. And right in the homologous area on the CT scan, where the densest part of the infarct was, it lit up with brain blood flow. And it turns out it was the area of the brain that controlled facial motor and oral motor. Now, she was hemiplegic, drooling, no speech, and unable to swallow, chew, and had essentially no facial and oral function on that side. And what I was saying is that brain tissue that on CT is presumptively dead, in fact, is living but not functional. It's stunned. And this is known in cardiac muscle, it's known in other tissues. But of course, never in the brain was the dictum. And
Right.
What happened with repetitive treatment, this lady reacquired function and eventually was able to talk, stop drooling, swallow, eat by mouth, and she even had assisted ambulation. And so what we decided to do was look at this with divers. And the first cases had been published in divers. Decompression sickness of the brain, you can only capture little tiny T2 spots in about, 10% of patients with brain decompression illness. And
Those T2 spots are those white spots that people see.
Exactly.
So white lesions that nobody knows.
You just see a few of them.
Yeah.
But it's a diffuse microscopic disease when the bubbles go through it. And so what happened, though, they started in England in 1988 doing brain blood flow scans on these divers who were coming in with neurological symptoms. And almost every one of them, they were positive. You could see it. So we decided to start looking at any chronic brain injury, including the divers. And that was the first one where we showed this. Then the second one, and I talk about it in my book and show the images. But we would do the scan after we'd done emergency treatment for them, but they had residual injury. We do the scan, next day, put them in the chamber. And after they came out of the chamber, we'd rescan them. And you could see these really unbelievable changes in brain blood flow that corresponded symptomatically. They would feel better. So we started doing that sequence for anybody with a chronic injury. But the second scan gave us information about that single treatment right before it. And what we saw in that scan was 3.5 hours after they came out of the chamber. So it was the delayed effect of what happened in the chamber. But you could never look at the brain in the chamber as you were delivering the oxygen and pressure. And I finally decided, I said, wait a minute, what modality can we try to look at live? EEG. And EEGs had been used before to look at oxygen toxicity in animals, even in humans. In Germany, this was done. But nobody had looked at it to try to dose somebody. And so I ended up kind of adapting this and then testing it And I have a wireless headset. We also have gel cap that we use that's wired out of the chamber. But I can put someone in the chamber after doing a QEEG outside the chamber, looking at it, getting it all quantitated, putting them in and going through a dosing profile of a variety of oxygen levels and pressures, and look at the brain live, record it, and get it quantitated.
You can see the brain change right in front of your eyes.
Instantaneously.
You can see the
I mean,
brain picking up the oxygen, changing colors.
The software is so cool because there are 3D maps you can
Right.
look at, as well as connectivity maps with rotating brain phantoms. And the delay from live brain to the computer is 30 milliseconds. I mean, it's essentially real time.
Yeah.
It's stunning. But I can now look at someone's brain and I can see where we are putting that brain in its best function at what dose, and or interpolate between doses. And that becomes the starting point for treatment.
That's
And then you still have to manage them clinically. I mean, it's not perfect, but it's
Yeah.
guide and it's helpful. And it's now looking into the brain real time. I mean, it's just, it's changed things. It's too cool.
No, I can imagine, because otherwise, you know, I mean, you have so many choices of oxygen, you know, pressure, and so much pressures to play with. And, you know, over the years you've learned, but like you say, the problem is you've learned what works for the situation, but then you still have that individual who's in the chamber, and maybe they're different. They're, you know, they're hardier, they're why they have the inflammation. I mean, that is the thing. I think that's what will be so interesting, you know, treating people with you know, long COVID, is just because one of the things that we discuss a lot in this series is how most of the people had something underlying. Maybe it wasn't obvious in a big way. There was a little fatigue. There was a little, like, maybe when I overdo, it takes me longer to recover than it used to, you know. There was often a little hint of some chronic inflammation that your body was handling. And then you get COVID and you kind of lose control. And so what you're doing is just kind of globally putting back a little the control again. You're rebooting, you're kind of rebooting the system. I mean, in a way, it's kind of turning it on, turning it off, and see if it can find a new balance.
That's a great analogy. You know, it's kind of like what happens and why you don't give a vaccine in the setting of an acute infection with inflammation and a ramped up immune system. So people with a chronic problem and low-grade systemic inflammation, COVID now is this massive immune response, depending on your comorbidities and genetics and everything else. And yes, it just amplifies your underlying problem.
Yeah. And so in general, I mean, I know I always ask you generalities when everything is about the particular patient, but still, you know, how many, when you're treating somebody with, well, I don't know if you have enough long COVID patients, but yeah, when you're treating someone, say, with long COVID, have you found that you need more or less treatments than you do for other issues, or?
It depends on how soon you can get to them. And the fact that it's immune related, hyperbaric oxygen and no other treatment will kill the memory cell responsible for the pathology. Unless you do a total chemical ablation of your bone marrow and, you know, start all over with a bone marrow transplant. I mean, we don't have any way of really killing the immune responsive cells that are causing, you suppress them. And hopefully by the time people have gotten spike protein out of their body and the ongoing stimulation of the immune system from it, the immune system can eventually die down, but you can suppress any response with the hyperbaric treatment. And the other thing it does is the inflammation and the injury it has caused, hyperbaric oxygen can help repair that. So depending on when you get, it can be less treatment, or by the time they've had it for a while, you know, you're getting up in the 4.5, 5, 6 month region. I tell people it's almost a guarantee they're going to need about 40 treatments, which is what it is for chronic wounding in just about any diagnosis in hyperbaric medicine.
Okay,
a
yeah. So
chronic wound diagnosis, chronic conditions.
right.
For
Well, because you're,
subacute and acute, it's less. You can
yeah.
suppress it easier.
Yeah, there's like you really need time for healing. I mean that is the thing. The body does take healing does take time. I mean the nice
Yes.
part is that many times we can ignore the healing happens kind of quietly in the background when we're sleeping, but when you really had an injury, it takes a lot longer than we'd like it to take. 6 weeks, 6 months is more likely than yeah.
Exactly. But what this therapy does is it stimulates all of those healing processes. So it accelerates the healing curve by all this gene expression, by all the other targets that hyperbaric oxygen addresses. So it speeds healing.
Yeah. Well, once again, and the amazing thing about the body and about, we talk a lot in this series and in other things that I've done about chronic inflammation and having, chronic infections, but chronic infections generally, sometimes you need to kill them, but most of the time you just need to reestablish immune surveillance and maintenance,
Right.
because a lot of these bugs are, can coexist. We especially like the viruses, they co-evolved with us. They're doing a dance with our system if we can just get them to get back into step. And that's what it sounds like the hyperbaric is doing. It's it's like rebooting your immune system back to a place where it was stronger, when
It
when the
augments
balance
those-
between inflammation and pro-inflammation and anti-inflammation was a little more in balance.
Yes. It
And then,
augments host defenses. Exactly.
yeah, so we still might need to kill a few things, but hopefully less.
And that's what it's doing in acute COVID. It is tamping down this tremendous cytokine storm and inflammatory response until the body's defenses and the immune system can become more balanced or regulated.
Yeah, no, that's I think that is, my story of chronic illness on all levels is just a failure to communicate. I mean, when the system is in a balanced communication, recovery does happen just like it's supposed to. Over a few weeks, people get better. And when you don't, well, most people don't remember Paul Newman and what was that, Cool Hand Luke. What we have here is a failure to communicate. That was one of the and that's what we have in chronic illness. So it's the giving the system a chance to recover. I just can't get over how, on one hand it sounds so simple, and I said before we go, do you have a one way of looking at, like, in your mind, why has this knowledge not gone far enough? I mean, what's been so frustrating?
That's actually the subject, part of the subject of a book that I wrote, is that when I was in medical school my junior year, the very first rotation in the hospital, basic medicine, I'm walking down the hall with the junior resident. And, junior resident is the main one who's doing all of your clinical teaching. And we walked by a group of doctors rounding outside this room of 4 patients. And I overheard one of the doctors say, well, how about hyperbaric oxygen for this patient? And, as a third year medical school, you don't know anything. And I waited till we were out of earshot. And I asked the resident, I said, what is hyperbaric oxygen? He said, oh, forget it. Don't even ask another question about it. It's unscientific, been thoroughly disproven, charlatanism, snake oil sales, and fraud. I said, oh, okay. And that was tucked away. This was gospel.
Johns Hopkins.
Yeah, Johns Hopkins. And
Yep.
8 years later, I'm down here in this diving medicine practice, and I went to the government course on physician diving accident management, taught by the National Oceanographic and Atmospheric Administration. And it was also embedded in it was all this hyperbaric oxygen therapy. Here were all these animal studies and some clinical studies showing the science of this. And it's like, where is the disconnect? And a lot of it happened, essentially, it was hyperbaric medicine in the United States. Nobody really knew anything about it in 1959, 1960. And as people started using it, people stood up and were making claims about it. Oh my gosh, I grew hair, or this patient with a stroke got better. The specialty of hyperbaric medicine, which was so immature, could not explain scientifically what was going on. And then my mentor stood up and published an article on treating some multiple sclerosis patients. And he was treating them for what was one of the accepted uses, a bone infection in their foot. And he said, wow, their neurological deficits got better, their MS got better. And there was a firestorm of controversy, because now he was saying that you could treat a chronic neurological disease that the entire neurology specialty had taught us it's impossible to treat a neurological disease. Well, and just to finish the story, here was this fledgling specialty fighting for credibility. They had now gotten it reimbursed in the hospital setting, and he was charging 1/8 of the amount in the outpatient setting. And the medical society, everybody went after this guy. And, the science of what he was saying was totally ignored. It was just, the whole thing got discredited. The medical society walked away from it and didn't want anything to do with it. And hyperbaric medicine got disparaged as, a treatment for diseases, nobody understands it, etc. And so my generation of doctors was essentially taught it was a fraud. And it's tough reversing that misunderstanding. So
Yes, it is. Yes. I can only say, and people, it's it's one doctor at a time. I mean,
yes, it
that's
is
the unfortunate thing,
one patient at a time too.
Yeah, I mean, and it's not, and I want people to always remember that it's not that there's this evil cabal. It's mostly just ignorance and an ego, getting together, because,
Right.
and that we depend on, in medicine, we depend on a few people to know the details, because there's so much to know. And when those few people make pronouncements, everybody else listens. And if those people are being motivated by their own self-importance, things don't move well. And just reminder that it was in 1980, my chief surgical resident told me that, as far as he was concerned, anything other than a total mastectomy was malpractice.
Right.
And, the Italians had proven in the 60s that it was useless. But it took how long?
Yeah.
I mean,
Which
so
person wasn't saying it, sure.
yeah. It's just, so be kind. Doctors are not out there to hurt you. They really they want to help, but we just are human. And again, ego and ignorance keeps us not moving forward sometimes.
Yes, and one of the other problems was the specialty of hyperbaric medicine couldn't define its own therapy. What they had done was, when asked, well, what's hyperbaric oxygen? They said, well, it's a therapy for recalcitrant, hopeless, and otherwise
Expensive?
yes, expensive, recalcitrant, and otherwise hopeless medical conditions. And so they defined it certain hopeless, expensive, recalcitrant, and hopeless medical conditions. Well, the certain was determined by this little committee of hyperbaric doctors. And what they did was they tied the definition to this list of diagnoses. They said hyperbaric oxygen is this. It's the treatment of these diagnoses. Well, those were historically ones that it had been applied to successfully, but it didn't tell you what you exactly were treating there. And so when people looked at that list, a diabetic foot wound, air embolism, chronic bone infection, compromised flap and graft, nobody could draw the connection. And the rest of the medical profession looked at it like, what? We don't understand this. And in the confusion is another reason why this got discredited. Now we understand it. This is an epigenetic therapy with two drugs, pressure and oxygen.
You created a new definition, so state the new definition.
Well, it's the use of greater than atmospheric pressure and pressure of oxygen to treat disease pathophysiology. So what we're not treating is, we're not treating a diagnosis per se. What's been shown is hyperbaric oxygen treats the underlying disease processes that cause the disease. And those disease processes are actually common to many different diseases. So what we have is a treatment for the underlying problems that are causing the diagnosis.
Right.
And it's somewhat generic, the effect on them.
Right. And you're 100% right. And now we just got to get the FDA to understand that that's a reasonable thing, because at this point, unless you have a specific diagnosis, the FDA isn't going to approve it for anything.
So, yes, I agree with that.
And hopefully they'll change their minds, because, this would be, as we begin to understand more and more the underlying drivers of disease, we can find treatments and understand that the names we attach to syndromes don't necessarily serve treatment.
Unquestionably, they're descriptive. You look at neurology, they're descriptive boxes that if you have a certain constellation of symptoms, you kind of fit that diagnosis. But it's not necessarily defined by the underlying areas of the brain that are involved in the processes causing it, Well, I think for a lot of medicine,
it's very hard. That I this is my theme, is that medicine is not science, and we have to apply scientific principles when we can. But if we if we worship the God of science, it doesn't. The God of science requires single variables. Okay, and that's not treating people. Until we figure that out, we're going to be very disappointed. We're going to treat, like we're going to do very well at some cancers that we can identify 3 or 5 genes, but the rest of medicine, we're going to be Band-Aid pushers anyway. But so let me think of the optimistic note is, hopefully we're going to help get the word out and get more people to realize that there is hope for a lot of the problems they're having, and especially, the long haul people with the neurologic diseases and the lung issues. Hyperbaric oxygen is something to think about.
yes, it's
And
happening.
yeah, and thank you so much for your work. I said I don't know if the patients who I've been kind of not. I've been in a kind of a student of medicine for a long time. And, I myself have gone down that path of being told that something is garbage, and you put it aside sometimes for 20 years until you bump into it again. And so that happens over and over again in medicine. So please keep an open mind to things, folks. We don't know everything. Just because the fancy doctor that they hire for TV says something, it could be true, but look a little deeper. So anyway, Juliette, Dr. Harch, Paul, thank you so much for your time. I really appreciate it, and sharing your wisdom and your life's work. It's a beautiful thing. So thank you.
Well, thank you.
Thank
And I
you,
want to say
Dr.
just one last thing, Dr. Gordon. This never would have happened. We never would be at this point had it not been for Juliette. This has been a team effort, and I can't go into all the details, but I will just say so much of this has happened because this was a joint effort. So
I saw that from the beginning. In fact, that's what Dr. Parpia, who had the privilege of meeting you both recently, told me. She met Julia, and it was like, aha. She could see it, because
the answer,
it takes a team.
It does.
Yes.
It does. It does.
Yes.
Thank you both.
Thank you so much.
you,
It's a great pleasure.
Thank you for tuning in to Dr. Talks. We hope today's episode has enlightened and inspired you on your path to optimal health. Each day is a new opportunity to make choices that empower your well-being. For more insights and strategies, subscribe to our podcast and visit our website, www.drtalks.com. Stay connected, stay healthy, and join us next time on Dr. Talks. Real talks from real doctors on the issues that matter to you most.